Terrific. Let's go ahead and get started. Welcome, folks. I'm really delighted to have you join us today for our presentation, latest presentation in our Indigenous Health and Wellbeing Colloquium series. We've been on hiatus for, it seems like it's been close to 2 years at this point, so it's really terrific to be back. And my name is Joseph Gaughan. I am Ani Grovant from Montana. I am a professor of anthropology and of global health and social medicine at Harvard University, where I conduct research at the intersection of culture, coloniality, and mental health in Indigenous communities. And I've been hosting this series for a few years now to bring esteemed and established researchers to come talk to us about this important intersection of culture, coloniality, and well-being in Native and American Indian and other Indigenous communities. Delighted to welcome you here to Harvard University. We sit on traditional ancestral lands of the Massachusetts people, who we acknowledge both because we're on their land and because their peoplehood continues to endure. This is a jointly sponsored seminar series conducted by the Harvard University Native American program, of which I'm the faculty director, as well as my department at Harvard Medical School, the Department of Global Health and Social Medicine. And today it's my pleasure to welcome Dr. Kamilla Venner, who's going to talk to us today. Dr. Venner is a member of the Chitina Athabascan community in Alaska and associate professor of psychology at the University of New Mexico. Her research is centered on the crossroads of Western and Indigenous Science to culturally tailor or center evidence-based treatments for addiction. And I've known Kamilla now for many years. So Professor Venner, we're delighted to have you today. You're going to be talking to us about beading together Western and Indigenous science to improve well-being. So thanks so much for joining us, and we'll give the floor over to you. Feel free to share your slides, and we'll let you take it from here. Thank you.
Wonderful. Okay, well, thank you so much, Dr. Gaughan, for inviting me, and thank you, Ollie, for all your help. I'm happy to be here today with you all to share my work and how I've been working to bead together Western and Indigenous science. So my Atna Athabascan heritage comes through my mom's side, and she was born in the Native Village of Chitina. And so that's that side of the family, and then mixed European heritage on my dad's side of the family. And I've been now in New Mexico since 1993, so a long, long time. And so, yeah, definitely getting to be more senior in this field. Here on the right-hand side of my slides are like a little depiction of forget-me-nots, the state flower of Alaska. I always have to give a little disclosure here that I do have a conflict of interest management plan through the University of New Mexico due to conducting research on these evidence-based treatments and also providing consultation, often for other researchers, but communities also. So trying to disseminate some of these evidence-based treatments to those communities who are interested in them. And I also have a land acknowledgement. The University of New Mexico sits upon the ancestral lands of the Puebloan people of Sandia. Puebloan, Apache, and Dene people have been stewards of this land since time immemorial. So I want to pay respects to their elders, past and present, and acknowledge their historical and present trauma, as well as historical and present resilience, and want to honor the children and the future generations to come. So I would like to invite you to consider how you might want to honor your Native communities around where you work. Also, I don't know if you've been hearing about the horrible flooding that's happened in Western Alaska. And so I found a spot where you could donate if you want, and I'm sure they'll send these slides out. So this is an overview really of some of my life's work here. So I'll talk a little bit about why I do this work, talk about assessment and assessment validity, stories of resolving alcohol use disorder to highlight more positive outcomes. A lot of times our Western science is a little more focused on pathology. So just elevating the voices of our people. And so, a lot of my work is really focused on empowerment. And then get into some of the cultural tailoring of treatment, just a tad, just a little hint of it. And then my more recent work has focus on implementation science. And so how are we working with communities to culturally center these evidence-based practices and adopt them and hopefully sustain them? A little summary, future work, and open it up for questions. So here's my first beaded artwork that I bought from another Athabascan woman. So really my work has been, I guess, I've been trying to weave together heritage. So another thing I've been interested in is cultural identity and how do you work with intersectionality. And so, having two different, like a native heritage and a Western, Eastern European colonial settler heritage, and trying to figure out how those go together and how to bridge the best of both worlds. And the same with Western and Indigenous science. So, our academic institutions are heavily Western, and so trying to uplift Indigenous science, Indigenous voices, and again, finding the best from both of those worlds to improve outcomes and well-being among our Indigenous people, and then bridging what we find in research, wonderful evidence-based treatments and interventions and assessments, and then how do we get those into the practice world, so into community settings. So many times communities are not often using the evidence-based treatments or using them to their full extent. And there might be a lot of reasons for that that we can talk about as well. So my driving questions have been like, how generalizable are our psychological constructs? And so we'll talk about that a little bit. And then what should American Indian, Alaska Native, or AIAN people do with the best from Western science? So how do they become aware of it? How do they assess it? How do they determine whether it's right for them and how it can be right for them, if at all? And then how might my work inform science for the mainstream? So a lot of times when I go to conferences or these kinds of talks, I think these talks draw other people who are doing this kind of work in Indigenous communities. But I really feel like, and this needs to be tested, that a lot of the adaptations we make with our American Indian Alaska Native partners, I think it makes the interventions better even for mainstream. So we'll see what you might think about that as well. So you might be familiar with the weird samples in psychology. So weird stands for Western, cultures, educated, highly formally educated cultures, industrialized, rich, and democratic. So weird countries really only represent 12% of the world population, and yet psychology acts as if our research that's based on those samples are automatically perfect for everybody around the world. So not everybody, probably not any of you, but it tends to happen. So I think of my work with my American Indian Alaska Native partners as a way to test the generalizability of our science and really improve it. And I'm going to start with the strength, because in our field, we often are trained to start with the deficits. So whatever you're doing, if you want to get funding, if you want to publish a paper, usually you make an argument for why your area is important. And usually it focuses on deficits. What's the problem and why do we need more resources addressed and focused on that problem? And then you move into what you're going to do. Our partners are very adamant, I guess, that we start with the strengths. And I really like that. It really fits with my philosophy and my way of being in this world too. So American Indian, Alaska Native people have many, many strengths. It's why we have survived and thrived over, since time immemorial. So we have a lot around community and kinship and cultural identity. And so in those connectedness, all those pieces. So for me, my mom, my clan goes through my mom's side. It's a maternal line. And so I am from the Caribou clan or the Ujishu clan. And that really helps me understand my place in the community. And then when things happen and we need to gather in a community setting, I draw from all of my clan's clan people and clan relations to help me. So when my sister and I kind of put on a potlatch for my mom when she passed, well, we relied on all of our clans to come together and donate all the gifts that we were going to give, help with the food, help with preparing everything that there was. And that was a real source of strength. And that connection, was really healing. So we have a lot of different kinds of ways of being together. Spirituality, I'll be talking about today. That is really a strength for everyone. Even just clicking a box that says what your religious affiliation is tends to be protective in terms of mental health and, not developing substance use disorders, things like that. So in traditional practices and medicines have been shown to be protective, especially in the world of addiction, and helps people to recover and to stay recovered. And then just general holistic wellness. So I'll be touching on that as well. One more strength that I want to share with you that I'm not sure if you're aware of, if you've heard my talks before, I definitely try to always stick this in there. So when we look at the SAMHSA data and look at what's the percentage of these racial ethnic groups who were abstaining from alcohol in the past month, so had nothing to drink in the past month, you can see that down here at the bottom is the American Indian Alaska Native group. We have the highest rates of not drinking any alcohol. And this has been consistent over the last, I think, 5 years. Sometimes the Asian group might be a little higher or very similar, but that's very consistent. And that's not something we get out there. And it kind of goes down Hispanic, Black, multiracial, and the non-Hispanic white always have the lowest rates of abstaining from alcohol in the past month. So one of the reasons to bring this up is that, again, it's like an empowering, wonderful statement. And if people are in recovery, one of the best predictors of outcome is having support for abstinence. And so they should have a lot of resources of other folks that are not drinking for whatever reason. So I like to bring this up and welcome you to share this information with others to help counteract some of the negative stereotypes. Well, where do those stereotypes come from? Well, the other side of the coin is we also have high rates of substance use disorder. So in the past year now, the SAMHSA data from 2023 show that, again, American Indian Alaska Natives have the highest rates of substance use disorder in the past year, followed by multiracial, then white, Black, Hispanic, and Asian having the lowest rates. So this is where a lot of those stereotypes come from. And there's some basis to it, right? So this is a problem that needs to be addressed and is impacting our communities. And I'll show you something else that's really, you may have been hearing the opioid overdose epidemic. Unfortunately, American Indian Alaska Natives are also #1 here. I try to say, let's not be competitive. I don't want to be #1 in these kinds of ways, but unfortunately we have been. And even though overall, most of the opioid overdose mortality is coming down, that's mostly driven by non-Hispanic whites reductions. And we're not seeing the same reductions in American Indian Alaska Native folks, maybe a little bit of a leveling out here with this 2022, 2023 data. And just to point out that what might be the reasons for these health inequities, one of the dangers of doing work where we're focused on one population, like American Indian Alaska Natives, is people can erroneously believe, oh, that must be a biological reason for those health inequities and disparities. So interestingly, a lot of people don't know that there's no evidence for a different rate of metabolizing alcohol among American Indian Alaska Native people. There was one study, I believe in the 70s, that showed that there was, but it was highly flawed. And their non-Hispanic white group was hospital staff that didn't have much of a drinking history. And they were comparing it to American Indians who were like hospitalized, a long history of alcohol use disorder. So of course their liver had been damaged. And so it wasn't metabolizing alcohol that well. Many, many more studies have been done and there isn't a difference there. Also, people erroneously think that there might be a genetic predisposition for American Indian, Alaska Native people to develop an addiction. And we have the same genetic propensities as everyone else. There's nothing unique. And I guess one of the other reasons I want to share this is because when American Indian Alaska Native people internalize that erroneous belief that we have a genetic predisposition, a biological vulnerability, then it actually is associated with increased rates of having alcohol use disorder. So it's a very harmful misconception to have. And so I really want everyone to help share that. So why might we have these health inequities? It really seems to be driven by social determinants of health. So in general, higher rates of poverty among American Indian Alaska Native people, although some tribes are doing extremely well, so that wouldn't apply to everyone. Lower quality of education, formal education, often neighborhood factors might not be as safe or not as walkable, or even like access to healthcare. Many of our tribes here have to drive hours to get to our level 1 trauma center. So that contributes to worse outcomes as well. And even though we have the Indian Health Service money, it's woefully underfunded. And so that doesn't provide the best healthcare either. And then historical trauma, which we don't have so much time to get into, but that goes up right to, the past moment. A lot of treaties broken, boarding schools, just a lot of attacks on culture and all of those protective factors we would have had. So that's that. Just a quick word, you probably have heard about this in this series or might know about this already, but I just want to say ethically working with tribal partners does take a lot more knowledge and a lot more relationship building. So every federally recognized tribe and maybe state recognized and even the unrecognized ones are sovereign nations. So in order to provide or to do research with these folks, you need often, especially if you're on the tribal lands, a tribal consent. Although some tribes believe like wherever their people are, they want to protect them and know what's going on. Tribal approvals, and that differs by every community. And sometimes that's the tribal council, sometimes they have their own tribal IRBs. And sometimes there's a number of different groups that you need to get approvals from. And then maintaining the confidentiality of the community so that we don't accidentally stigmatize those communities. So unless that community says it's okay to share that tribal name, we don't try to share the community. There's been many examples of harmful research with American Indian Alaska Native communities. You may know of the 1979 Barrow study up in Alaska, at the tippy top of Alaska. The researchers came in, were assessing rates of alcohol use disorder, and then just had a media blitz of how high the rates of alcohol use disorder were, without consulting the community to understand what might that be, how do they understand it, what should the interpretation be, how do they present it. And it had long-term negative consequences for that town in particular, like insurance agencies pulling out, things like that, and also just for stigmatization, right? And then these things have happened even more recently. So in 2010, the Havasupai tribe had been partnering with the Arizona State University researchers, and then found out that they had agreed to schizophrenia research, but then there wasn't that much schizophrenia. So the researchers continued to do other kinds of research that were on diabetes, and then also questioning their own origin stories. And so that was very unfortunate as well. I guess I could say that after fighting Arizona State University for a while, they finally came to an agreement where Arizona State University is supposed to work more ethically and in partnership with the Havasupai tribe now, and gave them some money. And then using community-based participatory research, or some people will say tribal action research or tribal participatory research, just knowing that we come in and we have power differentials. Often the funding comes to the university and not to the tribe. So that's unequal. So just thinking about all the ways that we might know more about research or statistics or things like that. So trying to find ways to equalize that partnership so that both of us are bringing in our knowledge, making decisions together, whether that's design, measures, um, recruitment, interpretation of the data, and dissemination of that data, of those data. So you work on increasing research capacity there, sharing your findings for sure, not just getting information and leaving and the community has no idea what happened, and making sure that that research is for the betterment of the community. So sometimes they're tired of just hearing what are the rates of the harmful things that are occurring, but how can they improve, and how can we improve overall well-being? So the first area I want to talk about is assessment validity. So often psychology has been founded by non-Hispanic white men. These assessments are typically developed by non-Hispanic white people. That is changing as we diversify our workforce. So that's been really wonderful to see over my career. And so those kinds of measures often have unknown validity for people who are not non-Hispanic white. So I've looked at different models for alcohol, the development of alcohol use disorder. We've validated the DSM-5 alcohol use disorder criteria in one community, tested an orthogonal measure of culture in another large community sample to make sure those psychometric properties worked in that with that group, and they did. And what I'll present today is this cultural adaptation, psychometric properties, and outcomes of the Native American spirituality scale. And my past graduate student, Brenna Greenfield, who now works at the University of Minnesota Duluth as a faculty, led that paper. So why are we even talking about spirituality? Well, the indigenous folks, and also in New Zealand, which was so refreshing, really look at everything in a holistic way. Whereas often in Western science, we're looking at things, we're reducing things to little parts. And when we think about addiction in particular, a lot of our science focuses on the biological determinants. So genetics that might increase your risk. You know, let's see, brain functioning, brain scanning, things like that. And then psychological. So what is your diagnosis? Do you have mental health issues, sensation seeking, inability to delay gratification, or less ability or something like that, that puts you at increased risk for this? And then how do we help people heal from it? We don't often, especially in clinical psychology, which is my field, bring in the social factors or the spiritual factors. So some of the social determinants of health would fit here, right? So experiences of discrimination, the poverty, those kinds of things, oppression, historical trauma, that goes in there. And then also spirituality. So if you think about it, how often do you see spirituality really explicitly mentioned in academic settings, in academic talks? So it's really when how you treat something really depends on how it's conceptualized. And so if we're only paying attention to two parts of this holistic realm, then we're missing out on a lot and not probably meeting people's needs as well as we could. So I brought this measure of spirituality to one of my tribal partners, and it had been validated. It was the daily experiences of spirituality. It had been validated. The World Health Organization had used it in, I can't remember how many different countries, lots of different kinds of spirituality, even Buddhism. I think even atheists and agnostics were included in this. So I was like, this is awesome. I think this is going to be great. So I brought it to my partners, and I'm like, here's some of the items. Like, I feel God's presence. I experience a connection to all of life. I feel deep inner peace and harmony, and I'm spiritually touched by the beauty of creation. This makes so much sense with land-based, sacred places, things like that. So I thought I was so excited about this, and they were not excited about it at all. So they were like, no, that's not how we talk. And even though there was something in there like for God, you can put in whatever word makes sense for you, they were like, no. So we had to work with them to figure out what they wanted instead. And so there were 16 items originally, and I think that we ended up with 12. And so they came up with, I believe life is sacred. That's beautiful too. All things are related to one another. And you'll hear that like, our animal relatives, land, everything is alive with a spirit. And I'm spiritually touched by participating in my faith. So that could have been their dances or whatnot, their ceremonies, different behaviors. So now once you change a measure, now it's no longer psychometrically valid. So then we needed to test it. So Brenna and Kevin Halgren ran the statistics and found a 2-factor solution worked for this. So the factor 1 looked like spiritual behaviors, like the praying or dancing, things like that. And the factor 2 is more spiritual beliefs, like everything's alive with a spirit. And they looked for correlations with different variables, and they found that the factor 1, the spiritual behaviors, were correlated with a lower past month alcohol and cannabis use. So again, there's that protection. It looks like protection. Also associated with greater ethnic identity, which makes sense, and likelihood of preferring American Indian spirituality to other kinds of religion. Factor 2 didn't have any significant associations. They also looked for correlations between the different items and let's see, sorry. Okay, so I'm realizing the time is going. Let me just stay focused here. Another thing we often do in Western science is we pick something that's a deficit, like a substance use disorder, and then our outcome is whether that got better. So decrease in symptoms, decrease in drinking, decrease in heavy drinking days, increases in abstinence, things like that. So we looked at, based on having the treatment that they had, did they have increases in spirituality pre and post? So they did find the factor 1 overall did increase from intake to the 4-month follow-up. And even some of the items increased. So I wake up early and pray to the creator or ancestors at the 8 and 12-month periods was significant. I find strength in my faith and spirituality had significantly increased at the 4, 8, and 12-month. And factor 2 did increase from intake to the 8 and 12 months. An item, I believe all life is sacred, had increased at the 4-month, but then was no longer significant, but still high. So the adapted spirituality scale has good psychometric properties, so other people are welcome to use it and maybe adapt it to their particular partners, tribes, and beliefs. The spiritual behaviors were correlated with lower substance use, higher cultural identity, so that was wonderful to see. Spirituality itself increased from pre to post treatment, and the tribe loved that, right? So instead of just looking at not so good healthy behaviors went down, let's look at how wonderful things like spirituality increased. So it's an important construct to measure and include in substance use treatment. And I think with mainstream too, in the US in particular, I think it's still at least 82% of our population believes in God or a higher power or something in a sacred realm. So it's another way that I think we're not really meeting the needs of our mainstream folks either. And I believe this is being used by other tribes. I'm not sure about other indigenous groups. I'm going to tap my toe into another study. This was my first K grant out of my PhD program. And again, I wanted to focus on more positive outcomes. So how did American Indian Alaska Natives resolve their alcohol use disorder? Here are some earrings here that my dear sister made for me. She's really talented that way. So let's look at positive things and let's empower the Indigenous voices and learn from them. Instead of saying, here's what we found with the mainstream that works, tell us what worked for you. So one of the papers we wrote on this was called Whatever It Takes or All That It Takes. So the person was saying that they had been through treatment several times, which is very common. Usually it's not just one treatment episode, right? And they said they kept learning things. And then finally they said, okay, I'm just going to use every skill that I've learned and just throw everything at this. And that's what helped them to be free of their alcohol use disorder. So we had 55 American Indian Alaska Native people, 56% male. They had resolved alcohol use disorder for at least 1 year. I think people like 5 years now for more stability. 51% had learned English first and 66% had sought traditional healing. So I'm just going to share in here my qualitative interviews. And we just asked them, how did you know you had a problem? What did you do to overcome your alcohol problems? And how are you doing now? So we divided it into motivating factors, like what motivated them to change, and then what were the things they did. So some motivating factors here were children and grandchildren. I just kind of did it for my daughter and my granddaughter too. So I didn't want her to remember me as a drunk grandpa, but as her sober, fun grandpa. So that really motivated one person to get to resolve their alcohol problems. They had other negative consequences, seeing people die. That's what made them think about quitting, and then legal issues too. So I thought I was going to be released, but the lady was adamant with her decision that she was going to have me learn my lesson. And God bless her, because, sorry, I don't know if that's covered up for you too. If I can move that. Whoops. Okay, that wasn't good. Sorry about that. There we go. Back. Okay, I saw it, but I can't move it. Anyway, then that led to them being sober for 11 years. Now, what did they do? Some of the actions that they engaged in to try to overcome their alcohol problems was formal treatment. I just have to say that came at the end of their efforts. But one of them said, I realized treatment was for Native people too, and not just for the white man. So that was really good that they were able to see that. I think even a Western probably looking program could be for them as well. The 12-step program was helpful to a lot of people, but also not to some. It's just a relief to know I'm not in this by myself. They talked about spirituality. The only thing I really think is very vital about getting sober and maintaining sobriety is to have that spiritual base, whether it's organized religion, Native American religion, whatever it takes, or all that it takes. And they liked it when the rehab settings had more American Indian Alaska Native, especially clients, I think, but also other folks. So in doing this work, I often think like, what is common among American Indian Alaska Native people and maybe more mainstream research? So a lot of the motivations and actions that they shared were common with mainstream folks, but there were some unique things too. Like some of their motivations of seeing negative consequences in other folks, some of the actions, traditional healing, spending time with other American Indian Alaska Native were some of the things that they put forward that were more specific to them. So I like the positive message of American Indian Alaska Native people successfully resolving AUD. I think it's good for researchers, it's good for clinicians, it's good for American Indian Alaska Native people, and just trying to get that word out there too, that there's not just higher rates of substance use disorder, but also successful recovery stories too. More than one path of recovery. You can't just say there's one way to do this. What worked for one person didn't work for another. All of my participants were completely abstinent. There was no moderated drinking in this group. I'm not to say that there wouldn't be some, but I just can't speak to that in this group. Lots of different motivators, lots of different efforts. When I looked at this quantitatively, I asked them about 18 different things they could have done to overcome alcohol use disorder. And on average, they had tried 12 of those things. And again, they tried things themselves with friends, things like that. And formal treatment was the last things that they were trying. while this, there's a stage of recovery that takes great effort, is very difficult, many people got to a place where they said they were living life as it was meant to be lived. So they couldn't imagine how good their life had become. All right, so I'll move into culturally tailoring treatment now. I'm going to switch over to this bridge analogy. So one way to address substance-related health inequities is to use evidence-based treatments. There's also culturally grounded care, there's hybrids, there's a lot of different things people can do. But, our funding agencies in the US require evidence-based treatments. So a lot of our clinics in the communities, even on the reservations, are required to use evidence-based treatments. That's starting to change where Medicaid is being able to use, people can use Medicaid to pay for traditional healing. And I think it's just 4 states right now: Washington, Oregon, New Mexico, and I'm not going to say the last one because I'm not positive. I know Joe knows the answer to this. So in this area, I want to bridge Western science and Indigenous science too. So you might think that this bridge might be a bridge to recovery, and that bridge looks very solid, like good engineering went into this bridge, but it's very plain, right? There's nothing about culture on this bridge. It's just very generic. And so we're like, well, if we know it works with kind of mainstream folks, let's just give it to everybody because it's the best chance we have of it working with them. But it could be that some American Indian Alaska Native folks or people that just don't feel like they identify with the mainstream population in the US or Europe, they might see the evidence-based treatment as this bridge. And how safe and effective does this bridge look to you? How excited would you be to cross this bridge to get to the other side and get to recovery? So for folks that those evidence-based treatments looks like this, then I think we need to work on some cultural tailoring, cultural adaptations at the very least, if not elevating culturally grounded interventions. So here's some of Joe Gunn's work. So I think this is a nice way to help people understand too why that bridge might not look that welcoming. So on the left here, these are the evidence-based treatments. They often happen in a dyadic setting of 2 people in a room, or maybe a group therapy or a family therapy, something like that. But traditional healing can be individual, but it can also include the whole community. The whole community can participate. Evidence-based treatments still carry quite a bit of stigma. Some people might be happy to say, I'm going to my treatment for my substance use disorder, but I think other people might keep it on the down low or face, people's expressions and that stigma. Whereas traditional healing is an admired activity. People are happy and pleased and excited that you're doing that. Evidence-based treatments are secular. The only one that's not secular is the 12-step facilitation, and that did not come out of psychologists or Western folks. That came out of people with lived experience, and that's the only one that, spirituality is the core piece of that treatment. Whereas traditional healing is sacred, and of course, evidence-based treatments don't have an explicit way to include American Indian, Alaska Native culture. If it was just delivered as a manual, there would be nothing in there, most likely. Whereas, of course, traditional healing does preserve culture. So some reasons to culturally adapt evidence-based treatments comes out of Kathy Berlew's paper. So if the evidence-based treatment is tested and found to be less effective with a group, as it was in a Kelsen study with African-American folks, then you might think, I think we should adapt that. And they did go back with some of the African-American men and adapted it, and it was more effective in their pilot testing. But that's kind of that's a lot of resources, a lot of time, and that's sort of a hard route to go, right? Let's give it to you, and then if it's less effective, then we'll change it. If the evidence-based treatment is iatrogenic, so sometimes you find that the evidence-based treatment is associated with worse outcomes, or over time looks like it's causing worse outcomes, then you might culturally tailor it. and Latrice has a paper on that. I believe it was motivational interviewing with African-American folks. There's also some that have been group therapy for adolescents that led to worse outcomes. So that would be a bummer, right? Let's just give it to you. And then if it makes you worse, then we'll change it. Adaptation should happen if it increases the attractiveness of that treatment, the engagement into that treatment, retaining people in treatment, which is associated with better outcomes, and the outcomes are better, right? So here's some papers that show that that does happen. And then also if it's unacceptable. So that was my experience working with one of the tribes. They were not willing to test the evidence-based treatment as it was. They only were willing to do it if it was culturally tailored. So we did work with that tribe, and we had a little contest, and they came up with this beautiful logo. And this looked like to me at the time that it was the second randomized controlled trial of a psychosocial substance use disorder treatment with American Indian Alaska Native people. So for lots of reasons, tribes don't often like that randomized controlled trial group, especially if they think something's effective. They're like, why can't everybody get it? So a lot of times you try to think of a different design, but they were willing to do this to compare their treatment as usual to the adapted motivational interviewing and community reinforcement approach. We got the tribal approvals. We trained 2 bilingual counselors, which is really important in terms of capacity building, so that even when the funding's over, they still have those counselors with that training, and a research assistant who learned about, recruitment and consenting and, a lot of the different forms and data entry. So we had 79 participants, which might seem low, but that was over recruiting for what had been proposed, and 68% were male. So some of the things that they taught me was involved the introductions being culturally tailored. So in Western populations or Western settings, we often have a lot of boundaries. Just kind of introduce yourself by your name and maybe your area of training, and you might talk about your degrees or your licenses and your specialties in delivering things to try to increase their belief in you. But they told me that they were greeting the spirit in each person that came in to their office and into their treatment session. So I think, how many of you greet the spirit in the people you deal with? And if any of you know of yoga, you might know of the namaste, the highest part in me greets the highest part of you. And I think, wow, what a wonderful way to be greeted when you're maybe feeling down. You've been maybe dealing with a lot of people upset with you. You're upset with yourself. Maybe you don't even think you're worth getting better. And so I think this fights against stigma and really reaches in to empower someone like, oh, wow, they're seeing the best part of me and they're welcoming me in, right? So I thought that was really pretty incredible. And they introduce themselves in terms of their heritage and their clan. So if you're Native, they might say, like I did, I'm from the Native Village of Chitina, right? My clan is the Caribou clan. And so they would figure out if they're from the same tribe, if they had a clan relationship, and then they would call their client by the relative term, right? Come on in, Auntie. That's so different than how we interact with our clients, right? There's just such a professionalism right there, where there's so much more love and relationality in welcoming someone in as family. And I just think that that has to make a difference, so much deeper than what our Western training is. I remember one woman who's on one of our collaborative boards saying when she went into treatment, actually, she was in the hospital for an infection due to IV drug use. And the counselors were coming to the hospital to meet her, and they told her, you're one of ours. And she said they loved her until she could love herself. And that's part of how she got on the road to recovery and remains in recovery to this day. The other thing I'll say is the more you introduce yourself in a more traditional way, so even if you're not Native, you can say what your heritage is. So you can hear people saying like they're mixed European heritage, or if they know more specifically what it is, they might introduce themselves that way, and like who you know. So when I go back to my community, I don't just say, "Hi, I'm Kamilla Venner," or whatever. I will say that I'm Kamilla Venner and I'm the daughter of Roxy Venner. Right? And if there's no recognition, I'll be like, I'm the granddaughter of Henry and Etta Bell. There's no recognition, I'll be like, well, my aunt, my cousins, right? Until there's, oh, okay. And now we kind of know each other, and there's like this added sense of safety and connection, um and just it's just wonderful. So that just sort of points to things being different. And when I was in New Zealand, I noticed that not only the Maori introduced themselves in their language, but the non-Maori were also introducing themselves using the Maori language. And so those are some things that we can think about here to lift up different people if it's welcome, right? Some people might not like it if you're trying to use their language, but if it's welcome, that would be lovely. Another adaptation we did concerned motivational interviewing, and these are rulers. So in motivational interviewing, you're trying to help someone talk themselves into change and build up their own motivations to change. And one of the tools and techniques you can use, it has to do with rulers. And so generally you ask, on this scale from 0 to 10, how important is it for you to make a change in your substance use? And it's meant to find out what is making it important for them to make a change. And so you build on those motivations, right? And so I thought, well, maybe, I don't know how much you like to rate yourself on a scale. If it's like around pain, that was really common for a while. You know, when you're in pain, you might not know how bad it's going to get. So you're like, well, I better not use 10 yet because it could get worse, you know. So they came up with some words, and then they said pictures are always nice too. There was a lot of ideas here. So we have the words, it's not important for you to make a change. You haven't prepared the ground for planting. You're unsure about making a change. A seed's in the soil, but it hasn't been watered yet. It's important to make changes. Your plant just broke through the soil. And then it's extremely important for you to make changes. Your plant is ready to be harvested. And so this is all open to further adaptation. These green chilies will make no sense in Alaska because we don't do green chilies down there, but here in New Mexico makes a lot of sense. And also like a lot of things are in circles in a lot of tribes. So one of the Navajo people was saying, the life cycle's on a circle, and so maybe you could put this in a circular formation. So there's many, many different things that can be done to further adapt this. So unfortunately, in some ways, there were no treatment differences between our adapted version, which is here in this like bluer color, if you can see that, the darker one, versus this oranger color, which was the treatment as usual. So so the good news was that everybody did get better. And interestingly, there were very high rates of abstinence at baseline. And then we had a small sample, but we were not able to find any moderators or mediators of these outcomes, probably because they're both so similar. This tends to be something common. So a lot of times when you put two different treatments against each other, there won't be like a treatment effect. And I was looking at, I've looked at some other literature around this. There's some really nice studies that look at the unadapted treatment versus the adapted treatment. And that's been nice, but a lot of times they don't find differences there necessarily, or they might find some differences like around consequences. But they will find like mediators of like cultural identity doing better perhaps in the culturally tailored group. But it's very complicated. So I was kind of diving into that, trying to, talk about that. It's not really clear cut. So this traditional tribe was open to learning and testing two evidence-based treatments, but only if they were culturally relevant for them. Both treatment groups significantly increased their percent days abstinence. There were no significant treatment effects. That's consistent. I guess I already talked about that. But hopefully this provides a foundation for other tribes and indigenous people around the world and mainstream samples to see if they want to adopt some of these evidence-based treatments and how they would do that. I just have to say, anecdotally, my counselors, we would present often to the tribal council updates, things that were happening. And it was so wonderful. A lot of times they would switch over into their native tribal language, so I didn't know what they were saying exactly, but when they were speaking English, they were waxing on poetic about how the differences they noticed in their relationships, their clients' willingness to tell them when they were using or not, and they just felt wonderful. They loved these treatments once they were adapted. So my final area is culturally centered implementation. So let's see. So implementation science is meant to get the evidence-based treatments into the community and study what are the factors that help that adoption, help sustainment, things like that. So this study that I'm going to share just a little bit about today was culturally centering the delivery of medication treatment for opioid use disorder. So medication treatment for opioid use disorder is MOUD, which is the preference from the funding agency, instead of medication assisted treatment, which sort of relegates medication as assisting a different treatment, where they're really saying like medication is the first line treatment. So again, trying to bead together Western and Indigenous sciences. So implementation science, here's another way to say it: the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. So you're really working with like the staff. It's a program level intervention to improve the quality and effectiveness of healthcare services. Medications are the most effective treatment for opioid use disorder that we have at this time. There's a lot of barriers around that, so I led some meetings around that. So stigma of using medications such as methadone and buprenorphine, even though those are the most effective and help people like live and decrease craving and live a life in line with their goals and values. We had 2 external facilitators there. And what helped some of our partners be willing to do this was that, of course, their tribal communities were very concerned about those high rates of opioid overdose mortality. And the nice thing about buprenorphine is it can be delivered in primary care, so that overcomes some of the barriers that are associated with methadone. This was a 2-phase study to, one, partner with the collaborative board using the community-based participatory research methods, develop this culturally centered implementation intervention to support the integration of buprenorphine treatment for OUD. And then the phase 2 was to conduct the preliminary test of the intervention in 4 different programs that were serving American Indian Alaska Native communities using a stepped wedge design and mixed methods. So that way everybody got the treatment, the intervention. So here we were in October of 2019, meeting in Albuquerque in person at the Indian Pueblo Cultural Center. We had just so many different kinds of folks with us. We had ethnobotanists, we had traditional healers, we had, people providing the services, directors, all different kinds of wonderful expertise there. And then the pandemic hit and everything moved to virtual Zoom calls. So we moved to monthly board calls. And then we had some subgroups. So I led the traditional practices group. So we would talk about what are some of the traditional practices that these programs might consider adding or enhancing in their delivery of medication treatment. We had a measurements group to go over what were the questions we were asking, what were the measures, what did they recommend, and really wonderful things came out of that. Like one small community said, well, I can't ask my participant some of these questions because they are my relative. I'm going to see them, in the community. So we had to come up with a different I think it was a red cap on a little iPad or something, and they had to hand it to them, and then they asked that, and that made things better. They made the measurements better. They made everything better. We had one working on the implementation processes, and then we have publication meetings. So 2 papers have come out. They've been beautiful examples of working with the community to help us make sense and help us to share the information in the best way possible. So they've been wonderful. We have 4 different sites. Oops. One of these is not in the right spot. So just one is in Alaska, one is in Minnesota, one is in South Dakota. These are all over the place. And one is in Washington. So sorry about that. Don't look at the arrows. So I guess I can say that we're done with this. We have the approvals to start sharing these outcomes, but we are waiting because we're working in partnership on the primary outcome paper right now. So we have a draft. We've met with our partners twice so far, and to work on making sure that it makes sense and we're making the best sense out of the data that we have and the findings that we have. And that we're also delivering those findings not only to the sites, we're planning those, but local conferences, other newsletters, other ways that they want to disseminate it to get the word out. So that brings us to the end. 11:01, pretty close. So I'm always trying to find balance. That's another thing I'm trying to bead together, is the challenges that American Indian Alaska Natives face, and also the strengths and the positive outcomes. In the assessment world, some measures are valid with American Indian Alaska Natives, but they need to be tested, and that needs to be shown, not just assumed. Some measures need to be culturally tailored depending on your partners. And a lot of cultural constructs have not typically been measured in the substance use disorder treatment arena, and also haven't been like the outcome variable, like how is that improving cultural identity or spirituality. So I think that's changing. We have some really wonderful up and coming early investigators who are American Indian Alaska Native, and I'm just so excited to see what they'll be doing in their careers. In the treatment studies, almost none of our evidence-based treatments explicitly include culture or spirituality, so we need to work to change that. Cultural tailoring can increase adoption. So my tribe would not even consider it unless it was culturally tailored, so then they would adopt it. Hopefully it increases engagement in those services and retention. And a lack of treatment effects is not uncommon. We need to do a lot more research to understand what makes treatment effective. Implementation science may help bridge that gap between research and practice. And I really believe that our research is generalizable to other tribes, other indigenous groups, and also makes things better for the mainstream too. So many questions left to examine. Some of my future work, here I am over here in front of a marae in New Zealand. Didn't get a chance to talk too much about this, still sort of incorporating it, but they let us learn a Maori song. We're working a little bit with these poi, but the people are really good at it. They're swinging around, banging into each other, which is a percussive noise. We just barely could do anything with it, but it was really wonderful. And so like having the training in a traditional place was really beautiful. They opened it up with a traditional ceremony. And it was just woven in throughout. It was just really beautiful. So I really want to delve into cultural identity development and how we can guide practitioners to work with people who want to talk more about their cultural identity, or maybe, process where they're at. There's a lot of emotions in a lot of the different stages that can be very difficult to deal with as you're trying to understand how different cultures fit or don't fit. I want to look at some of the Maori models because they more include spirituality and ancestors and land and everything that aren't usually in our Western models. And then maybe start with some qualitative studies to see what our American Indian Alaska Native communities think about this guide. I just wanted to show you this wonderful example of culturally tailoring and an intervention where they bring in Western science here on the right and the brain, and they talk about the brainstem and what it does and what's going on there in a very uh, deep level and also understandable level. And then they related that to the building of the marae. And so it was deeply steeped in Maori stories, Maori knowledge. And they compared the back of the marae, this po, to the brainstem. And then they talk with families with children who might have some neurodivergence, and how would they, what are their strengths and what are their areas of need and to focus on. So that was really a beautiful example there too. Lots of people to thank: mentors, collaborators, graduate student RAs, postdocs, admin staff, funding agency, our collaborative boards, our tribal partners, and the participants. And with that, thank you. I will end for today and open it up to questions. These are some beaded moccasins my dear grandmother had made for me when I was small. And speaking of culture, this is not a typical flower. I don't think that was ever used in our tribe, but she would just continue developing and take her inspiration from whatever she saw, and allowed herself that freedom.
Fantastic. Wow. So, Dr. Venner, that was just an amazing tour de force overview of all of the different issues as we think about SUDS treatment and SUDS research, and how to partner with communities, and how to take stock of culture and spirituality. And so I'm really grateful to you for bringing that wealth of information for our audience. We had maybe over 140 people joining us at one point or another. And I'm just thinking about a lot of those folks, of course, are really familiar with addiction treatment and know something about substance use disorders, but not necessarily everyone would. And I wonder if you could just describe for us a little bit, since evidence-based treatment is really what some of our professional guilds really promote, and for reasons that have to do with a scientific assessment and evaluation of outcomes, wanting to be accountable to actually doing good in the world. Can you just, since you talked about your motivational interviewing, your community reinforcement approach, the medication for opioid use disorders, can you just describe in kind of thumbnail sketches what those entail, so folks who aren't so familiar with addiction treatment proper understand what those treatments really sort of do in a few sentences or so?
Ah, gotcha. So, being more senior in the field, I'm more into the older school kind of treatments of motivational interviewing, cognitive behavioral therapies, community reinforcement approach, things like that. So the motivational interviewing is really helping somebody look at their own life and see, well, how do you view it? How do you view your drinking or your opioid use, right? And how's that working for you in your life, and how's that not working? And so you're really working to understand their perspectives and see where their motivations might lie. Like I was talking about some of the other studies that were qualitative, like, so I don't want to be this role model for my children or grandchildren, right? So there's my motivations. And so where are their motivations, instead of me trying to put my motivations in, like, hey, you're having all this legal trouble, or you lost your job or something. I need to know what matters to them and help them build that up, build upon what matters to them. So motivational interviewing is so lovely in that way, very client-centered. Um, is that what you're kind of asking, Joe? Like,
Yeah,
how do
yeah.
those things look? And then the community reinforcement approach, it's really, those kinds of things are more around skills, really. So like, how do you recognize what your cravings are and when those happen? And so let's map that out for you. Let's have a functional analysis of that so that we can interrupt those pathways and replace that. So if you want to use to relax or forget about your problems, let's find other ways for you to do that. Let's find ways to manage your emotions or seek social support or communicate better. Trying to think of some other things that you do around that. So it's kind of more skills-based oriented. Now there's more like meditation, mindfulness practices and some other things. Oops. It looks like my internet went unstable. Am I freezing?
You were freezing a bit, but we heard you, so we could,
Okay,
so maybe, thank
hopefully
you.
that passes.
Yeah. Thank you for that. That's terrific. And so it helps open up for folks who aren't as familiar with addiction treatment approaches, some of the black box stuff. You know, another area in which we have black boxes in a lot of our research presentations when it comes to Native well-being is what we call traditional practices. And of
Oh
course, you
yeah.
mentioned traditional practices. You talked a little bit too about, you know, like calling people by kinship terms, for example, when you welcome them into the treatment center, which is a way of, you know, a shift of reframing away from the kind of professional distance, you know, the authority of expertise and all that kind of stuff that can be more welcoming. But what are some of the other traditional practices, and especially if there are one or two you could describe just a little bit so people have some sense of what we mean when tribal community
Mhm.
members say traditional practices could be helpful for these sorts of
Right.
challenges?
So it's such a wide range and so much difference between, various tribes. But it could be something simple. I'll talk more from what I might know. Like some of the traditional crafts, like beading, right? So making jewelry, pottery, those kinds of things. It could be about traditional food gathering, traditional plant gathering for traditional medicines. Um, I know when I was up in Alaska, I tend to get bug bites, and I got a bunch of spider bites while I was berry picking with my grandma and my mom, and they were just like looking terrible, swelling up, terrible. And my grandpa just reaches into the refrigerator and had some medicine already made up, and I was putting that on my bites, and they were fine. So it could be that, it could be growing traditional foods, eating traditional foods, hunting, to more like ceremonies, like people might have heard more of sweat lodges or talking circles, sun dance. So there's just, wow, it's so broad, it's so big. I don't know if you want to say more about that too, Joe. I know you're thinking about this a lot too.
Yeah, no, thank you. That's terrific. I think we just want to give people a, you know, some sense of what these might entail. So thank you for that. And you know, there's so much that we could talk about, of course, and all of the material you put on the table for us. But I am aware of, along with your randomized control trial, which you described as only the second one to ever undertake psychosocial with Indigenous folks contending with SUDS. You know, these are few and far between when it comes to Indigenous health concerns. Our randomized control trials are often said to be the gold standard for, you know, isolating cause and effect relationships in these big kind of treatment evaluations. So few of them done with Native folks, yours being one of them. And there are a handful of them now, which you kind of acknowledged, that have, you know, tried cultural adaptations or even tried cultural approaches or practices and found that they really don't necessarily perform much better on key outcomes around, you know, treatment as usual, as they would say. So, you know, what do you make of that? Because, you know, so many of our community members are just convicted that, you know, cultural adaptation is everything, cultural
Mhm.
practices are the right way to go. And yet we have a handful, often smaller RCTs, but RCTs are very hard to do anyway, much less in Indian country. So we're
Yeah.
lucky to have the ones that we have, including yours. But what do you make of this fact that sometimes there just isn't evidence that there's any better outcomes?
Yeah, I do think about this quite a lot because of course, I was very disappointed that I didn't have any treatment effects either at the beginning. Um, but I think that that is what happens in research. In Project Combine, there was 9 different treatment arms, and like motivational interviewing, or Project Match even, there was fewer, but the main motivational interviewing, cognitive behavioral therapy, 12-step facilitation had equal outcomes, and there was no difference. And so, easy places to look are like fidelity. Were these treatments delivered as they were meant to? Did they stay true to those? Well, people are getting better and better at making sure that the fidelity is being met and tracking that really well. Um, I think, well, the treatment itself isn't the only ingredient. So there's therapist effects that are probably as important as the treatment that you're choosing. So do you have empathy? Are you understanding their perspective? Are you collaboratively setting goals? Do you have a good therapeutic alliance where they trust you? Maybe even charisma, like, right? and belief, right? If I believe you're going to get better, even if it's because of, you're in a study and the researchers told you that these groups are getting better, but they're not, it's just random, that belief in their ability to get better really matters. So there's a lot of therapist effects, there's client effects of motivation. So yeah, I'm having a hard time really understanding that too. And I think, well, do we really know how to culturally tailor these treatments? Are we doing a good enough job? You have to culturally tailor, but also maintain fidelity to the original treatment. We don't really understand mechanisms of change, so that doesn't always come out either. So motivational interviewing, it's like, okay, the more the client talks about change and why they would change and change talk, the more likely they are to change. But a lot of our treatments don't, that the mechanism of change isn't really being borne out. Like, you got CBT, did you get some skills? And well, that didn't really get borne out. So there's so much we don't know. And so I don't know if it's measurement. We need things that are more designs that are more complicated, statistics that are more complicated. um I'm really unhappy so far with our measures of cultural identity and maybe even spirituality. So yeah, I am not sure what to make of it, but I think that relationship has a lot to do with it. But that doesn't mean that you can just do whatever and just have a good relationship either. So I think it's pretty, yeah, I think a lot more work needs to be done.
Yeah, yeah. Well, thanks. And, one person did ask in response to your description of the RCT, was there any consideration of outcomes other than percentage of days abstinent? For example, could clients have been consuming more safely post-treatment or reducing their quantity
Oh,
consumed?
I love that question. So this was a long time ago. So, and I think it's still the case that when you propose your study, you have to kind of put your eggs in one basket. And so you're like, okay, percent days abstinent is where we're going with this. But that's really changing because we know if people can reduce their drinking substantially, that is also related to a number of better health, better functioning, those kinds of things. So I love where that question's going. um, I can't remember. I think we looked at consequences. We did look at spirituality, but that's kind of different. Um, but yeah, we didn't. And then another problem we had is we had such high rates of abstinence. So I think with our groups, there's high rates of abstinence and high rates of heavy drinking. So there's not a lot that's in between. So I think that makes it a little more difficult. And like in my one study, when I asked folks who had resolved the alcohol problem, they all were abstinent. And so I don't know. I just tend to think that there's not a lot of space in Indigenous Native American places to have acceptable drinking or substance use. So I think that makes it harder to look at like reductions like that, because it kind of seems like it's a little bit more like an all or nothing. But I do like that idea of harm reduction and really noticing how important it is to reduce your use.
Thank you for that. It speaks, I think, to the degree to which Alcoholics Anonymous and the philosophy and approach in Alcoholics Anonymous has been taken up for recovery movements within Indian
Mhm.
country, because AA famously embraces a disease model of alcoholism, which sort of says it's abstinence or nothing. You're always one drink away from a drunk, those kinds of ideas. And yet harm
Mhm.
reduction is sort of a totally different take on those things. What have you found in terms of Indigenous openness and embracing of harm reduction approaches?
Well, I really feel like the opioid epidemic has forced the issue. So, given that our best treatment to keep people alive is prescription opioids of buprenorphine and methadone, that is a harm reduction approach, right? In terms of alcohol, I'm less clear when I have my collaborative board members, people who are treating folks, people who have lived experience, they seem more open to a harm reduction approach. Like, let's meet them where they're at. Let's start moving in a good direction. If people don't want to be abstinent, that could be another huge barrier to starting to seek formal treatment. So I don't know myself. I think it's been pretty a pretty tricky area because I think a lot of tribes don't want to talk about any um alcohol use, right? It's like it is kind of abstinence only, but I think it's an area, maybe the opioid, overdose epidemic is going to open that up more so that people will feel more comfortable with like, let's keep people alive, let's get them into treatment, let's start with where they're at. A lot of times you'll work with people to have a more moderated drinking goal, and they realize after a while that they're just having too much trouble. They can't make that goal. And then that might lead them into a newer goal of abstinence. But in the general population, people who have alcohol use disorder, maybe 20% are able to then later moderate successfully.
Yeah, wow. Good to know. We have a question from Haryata Tyrakena at Hopkins, or was it Hopkins? I see you have found the importance of cultural adaptation from your community and others, and it makes me wonder why not start from the ground up to build a culturally grounded program?
That is awesome. Well, I think people are doing that now. Um, I think for me, it was a little bit about where I was from. So in my cultural identity development, my grandparents were converted to a very, I'll just say, a strict kind of Christian religion that said that, our native ways were evil and you're going to go to hell, basically. So you can't have those. So they gave up quite a bit of that. They didn't teach their children our language. I didn't get the language. I don't have an ear for language. So I would try to ask my grandma for stuff. I couldn't get it. So, I mean, I think that was really where I'm like a deficit for me. Like I wasn't raised traditionally. So a lot of my work has been to reclaim some of my traditional and cultural identity, right? So I don't feel like that was my expertise, but I think that was part of me going to New Zealand because I know they are much more culture forward and culture first. And I wanted to kind of detox from this Western way of like evidence-based treatments, and just surround myself in, places where they really do believe in that. So I think that is the way to go. And I think I could feel more confident working with folks, but again, it would have to be the partners that develop thing. And I know that Joe has done some of this work himself with his community and other communities, like trying to develop the traditional culturally grounded ways of healing and testing that. There's a lot of caveats with that too. Like even in mainstream, people didn't want spirituality to be studied, or are you going to study that prayer works? Well, what if your study finds out it doesn't, and then people will be upset about that. And so there's just a lot of, and then for a lot of the things, like I didn't mention it, but Native spirituality, a lot of it's sacred and secret, and we're protecting it because it was under attack, and only certain people can know certain things. And so you want to study it, but we can't then say, well, here's what they did, and here's how you do that ceremony, and and so a lot of it, so there's just a lot of things to figure out. But if we can work with our partners and our funding agencies, I think they're much more open to looking at the culturally grounded interventions. And I think that is a wonderful next step. And I don't know that I'll be getting to that, but I do hope that I see that there's now the N Crew through NIDA that is funding tribal communities and tribal programs directly. So traditionally, the NIH, National Institutes of Health funding, went to the academic institution like UNM. Then I do a sub-award. I don't know, I think there were sub-awards before, but a sub-award with the tribal partner. So they have their own budget to take care of things and support the research.
Thanks. Our time's drawing to a close here, but let me just say, as an aside, so many people in our communities embrace Christianity in various ways, shapes, and forms. Sometimes that Christianity is very open to traditional practices. Other times it's not so open. And have you ever heard of advocates in communities wanting spirituality incorporated into addiction treatment that's Christian-based more so than traditional-based?
I mean, in my own family, I would hear that. I don't feel like I've really seen that quite as much in the work. I mean, in my qualitative work with the recovery, some of that was like a Christian religion that helped them. And Sometimes the AA was a more Christian spirituality, but I would just say it's complicated, and I'm sure there are folks that are just Christian. I know there are, and that's what they would want, and not a culturally grounded intervention. And I mean, I really had to be careful what I even told my mom about my work, because she would be very nervous, or my grandparents, about the stuff I was doing that was like, more about traditional ways. So,
Yeah.
yeah.
Such complex roads we walk, huh? It's something else. So last question here, which comes from an anonymous attendee, which has to do with, the importance of engaging partners around how to proceed in these things. On the topic of using CBPR, I'm curious what you think about using community engaged approaches versus full CBPR. This person agrees that CBR is great, but says that, there's ways and opportunities to do maybe a less rigid, less stock version. I wonder what your thoughts are about community
Yeah.
engagement in general.
Well, I would say that I've been learning along the way anyway. So a lot of my work has been more community engaged than CBPR proper. And I think I've thought of that as the expertise I have to bring is around addiction. So the topic is going to be addiction. So I'm sort of like throwing that out there right away. So that's not really full CBPR. Like, what are you interested in? So I just feel like, well, that's what I have to offer. And, if you want a partner, then we can kind of focus in that area and then move from there. There's a wonderful article by Key, that describes like the whole continuum of community engaged work from not at all to like full CBPR. I would say the last study that I was starting to share on the implementation of culturally centering the medication of opioid use disorder, that is probably the most fully CBPR study I had. And that's because it was funded through NIDA Clinical Trials Network. And that was like a lot of funding, the most funding I've ever had for a project. So I've had like a tiny R36, which was not enough funding to support this kind of work, with a lot of challenges. And so that one, we could really pay our community advisors well for every meeting and coming in, and that was the way that we were more able to really do more community, a high level of CBPR. So I don't want that to be like an out, like, oh, if you can't do it, you can't do it. I think people should try to incorporate as much as they can. So it might include hiring folks. So I've heard of people doing work in different countries, and I'm like, well, who on your team is from that country? And they're like, oh, no one. I'm like, okay, that concerns me.
Right. Well, and it's also helpful to remember that there are disciplinary traditions around this. So CBPR comes out of public health. You and I are psychologists, and there's been
Yeah.
a long-standing participatory tradition within psychology research coming primarily out of community psychology, which has been around for 55 years or so. So anyway, just a plug for psychology and different approaches to managing participation. We've come to the end of our time. And so, Professor Venner, I am so grateful to you for having joined us at this Indigenous Health and Wellbeing Colloquium series. You've been a fantastic presenter, and it's good to reinitiate this series with you sharing all that you did. So thank you very much. If we had a big audience, which we do, but they were visible, we could all clap for you. You see the hearts, you see the well wishes coming in. So we're really grateful. And just to remind everyone, this colloquium series is jointly sponsored by the Harvard University Native American Program, of which I'm the faculty director here at Harvard University, as well as the Department of Global Health and Social Medicine, where I am a faculty member at Harvard Medical School. We're really grateful that you're coming. We plan to have these again on and off. So let me tell you just briefly before we close about the next one, which will be on November 12th, which is 3 weeks from today at the same time in the same way through the Zoom. That's from noon to 1:30. It'll feature Dr. Lawrence J. Kermayer from McGill University, and he's going to talk to us about Indigenous knowledge, epistemic communities, and the politics of pluralism. So I'll be sending around advertising again, but please plan to put that on your calendar and register and join us again next time for our ongoing seminar series. I also want to thank Alejandra Racon, who has been working to get this set up for us. And this is the first time that we sort of tackled this sort of webinar format here at HUNAP. So it's been a fantastic job, Ali. We really appreciate it. Thanks, folks. Really wonderful to spend time with you. Look forward to seeing you next time. And thank you, Professor Venner.
Thank you so much. It's been my pleasure.
So long, everyone. Bye-bye.